Good morning, everyone. Can you hear me?
Yes.
All right, so I have no disclosures for our topic today. I want to thank the course directors for inviting me to speak this morning. Our agenda is as follows. Today, we're going to identify features of eosinophilic esophagitis.
Dr. DeLay, do you mind sharing your screen?
Oh, I'm sorry. I thought it was. I apologize. Doesn't seem to be letting me, Dr. Patel.
I can certainly share from my end in advance as you advise.
Okay, that would be great. Can you see me now?
Yes.
Great. So review the diagnostic workup of eosinophilic esophagitis and recognize the pitfalls that we notice when we take esophageal biopsies in diagnosis. When to examine our treatment options and review the updated consensus guidelines, and then characterize which patients could be good candidates for maintenance therapy. So we've learned a lot about EOE over the last 30 years. There have been several different iterations of our consensus guidelines. The most recent were published in 2018 and were the result of the AGREE conference. But actually an important landmark study was done in 1995. This was from an allergy group from Johns Hopkins. And they were examining a group of 10 pediatric patients who were thought to have eosinophilic esophagitis or eosinophilia related to GERD. But treatments aimed at improving the symptoms and the histopathology like acid suppression and the fundoplication did not improve any of those parameters. So then they placed these pediatric patients on an elemental diet that excluded dietary protein. And from this, they showed a marked improvement in symptoms and histopathology. The incidence rates of EOE have been studied primarily in population-based studies out of North America and Europe. And all studies that have been done so far have shown that the incidence rate of EOE is rising rapidly. The prevalence in the US is currently estimated to be about 1 in 2,000. So what is EOE? EOE is a Th2-mediated inflammatory condition of the esophagus. It's food antigen driven, and importantly, it's a chronic process. It's frequently associated with atopic conditions, including asthma, allergic rhinitis, and eczema. When we think about the disease activity of EOE, we think of it in two ways, with both inflammation and tissue remodeling included. So inflammation is our histology. This is our esophageal eosinophilia that we're all familiar with. But we all need to think about tissue remodeling as well. So it's really a transmural process that includes both mucosal expansion, the subepithelial fibrosis, and because of these, the dysmotility that can occur with in the esophagus. Dysmotility is primarily evaluated with an endoscopy or with an esophagram, and in some centers that have this technology, EndoFlip, which evaluates the distensibility of the esophagus. So we think of EOE as a clinico-pathologic diagnosis, and first off, we want to evaluate symptoms. So symptoms commonly include dysphagia, atypical chest pain. Patients often have a history of food impaction. They sometimes can have heartburn as a symptom as well. And then the pathology. So one or more biopsies typically have greater than 15 eosinophils per high power field. But we have to remember to exclude other causes of eosinophilia and also ensure that the eosinophilia is limited to the esophagus alone. So while EOE and GERD are the most common causes of esophageal eosinophilia, we always have to think about connective tissue disease, achalasia, Crohn's disease, and these other entities, hypereosinophilic syndrome. Although, again, EOE and GERD are the most common causes of esophageal eosinophilia. So for our endoscopy, these are classic features that we see in EOE. Panel A shows mucosal edema, followed by these rings, linear furrows. Panel D shows us stricturing of the esophagus. E shows us exudates, which are actually microabscesses. And then F shows us crepe paper esophagus, which is when, with advancing the gastroscope, you actually cause a mucosal rent or a tear in the esophagus. Remember, the #1 cause of food impaction currently is actually EOE. And we've all seen this image typically at 2 a.m. in the morning for food impaction. But gastroenterologists should remember that to continue the process of the workup for the patient, that we really should be biopsying for EOE at the time of the food impaction. And you can either start a PPI and schedule a patient for follow-up with a gastroenterologist, or wait for biopsies, but ensure that they have that follow-up visit scheduled. Tips for biopsies. So always biopsy the areas of apparent inflammation to increase our yield. And this is the exudates and the furrows that you see. So if you're biopsying the rings or the mucosal edema, you may decrease your yield and kind of alter how much disease activity you're seeing. Remember, there's no location of esophageal eosinophilia that's been shown to predict EOE versus GERD or response to PPI. So we'll often hear that, well, the proximal biopsies showed less eosinophils than the distal biopsies, but that doesn't necessarily mean that these biopsies are because of a GERD-related process. And P counts can be variable throughout the esophagus. So this was an esophagectomy specimen from a patient with EOE, unfortunately, and they were able to take longitudinal biopsies circumferentially around the esophagus. And the red line that you see here denotes 15 eosinophils per high power field. But look at the surface area that did not or had fewer than 15 eosinophils. So if you're biopsying in one of those areas, you may not necessarily capture the amount of disease that's present. So it's really important to ensure that you're biopsying in these several areas. When we think of the treatment of EOE, we think of the 3 Ds. We think of drugs, diet, and dilation. For drugs, we think of proton pump inhibitors, topical steroids, and biologic therapy that's coming up the pike. For diet, we have empiric elimination diets and allergy-based testing. And for dilation, we want to combine this with therapy, and we'll talk a little bit more about that later. So drugs, proton pump inhibitors. They're now considered to be first-line therapy for EOE. So prior iterations of the consensus guidelines had this separate entity called PPI responsive esophageal eosinophilia. And so that required an 8-week PPI trial to see if patients had this kind of separate entity from EOE. But in 2018, the agreed consensus guidelines showed us that PPI is really our first-line therapy. And whether you're PPI responsive or not, we're all calling it EOE. But why do they work? So GERD and EOE as 2 separate disease processes could overlap, and symptoms certainly do. Erosive esophagitis from pathologic reflux disease could increase antigen exposure through disruption to the mucosal barrier. And we know that PPIs have a role in the inflammatory cascade through eotaxin 3, and this contributes to eosinophilic migration. Topical steroids, want everyone to know that we have no FDA-approved medications for EOE. So the topical steroids that we use are actually asthma approved. But we can use fluticasone, budesonide. So this is a liquid formulation that we typically mix with Splenda or honey to increase the viscosity of the formulation to improve the hang time in the esophagus. And then we have oral dispersible budesonide tablets. These are only available in Europe right now. It was previously thought that budesonide was actually superior to fluticasone in treatment of EOE, but a randomized controlled trial by Dellon and his group published last year showed that there's actually no difference between budesonide and fluticasone in response, in dysphagia scores, or in the histology that you see with EOE. So either can be used, patient preference or insurance preference. But we know in patients that have even achieved deep remission with topical steroids, that in 82% who were taken off of therapy, relapse occurs within a median of 22.4 weeks. And this essentially reiterates that EOE is a chronic process and relapse truly is the norm. So what's coming down the pike and why? It's reasonable to ask why we need other treatments for EOE. Well, as I've alluded to, steroid non-response and loss of response is not infrequent. Dietary therapy can be burdensome. And then there are severe phenotypes of EOE that do exist. And the most classic example of a severe phenotype is fibrostenosis leading to a very narrow caliber esophagus. And while the best recognized cause of the fibrostenosis is thought to be chronic inflammation, Work by Dr. Menard Ketcher in the pediatric population have showed that fibrostenosis can actually occur much earlier in the disease process. So this could represent a different phenotype, and it shows us that we may need more medications and different options for people that either don't respond or can't tolerate treatment. So IL-13 and IL-4 are pathways that are implicated in allergic diseases, and this includes EOE. Currently, we have 3 biologics with promising phase 2 results. There's an anti-cyclic 8 receptor agonist. It has activity against eosinophils and mast cells. This is showing pretty good data in phase 2-3 trials and is actually available at the university. Dupilumab, which is an anti-IL-4 and IL-13 biologic. And then we have an anti-IL-13, so RPC 4046. And the primary outcome for this is histologic response. So dupilumab, this blocks, as I mentioned, both IL-4 and 13. And whereas previous data for biologics have shown improvement really only in histology, dupilumab showed a significant improvement in dysphagia and also severity of histologic and endoscopic features, esophageal eosinophilia, and the distensibility as evaluated by EndoClip. Diet. So there are multiple iterations of elimination diets, and maybe most commonly known or commonly used is the 6-food elimination diet. You can see here by far, cow's milk is the most common trigger of EOE, followed by wheat, gluten, egg, soy, and then multiple studies now have shown that seafood and tree nuts actually rarely are triggers for EOE. So for the 6-food elimination diet or any empiric elimination diet, there are 3 phases that start with induction, followed by reintroduction, and then the maintenance phase. So in the induction phase, all 6 food groups are eliminated. And then reintroduction focuses on introducing the foods that are least likely to trigger esophageal eosinophilia, followed by the most likely to trigger. So fish and nuts are reintroduced first, followed by an EGD. Then soy and egg, followed by an EGD, and then finally wheat and milk. And each are followed by an EGD at that point as their most common causes. But remember that 80% of EOE patients will have a primary trigger. So this should typically bring out which trigger that is in this stepwise fashion. The other variations, there's the 4-food elimination diet, which essentially eliminates the tree nuts and seafood portion. And then there's a really interesting step-up approach, or the 2-4-6 approach. So this was evaluated in a multi-center study from Spain. There were 130 patients, some of which were children, and these patients underwent a 2-food elimination diet, which was milk and gluten, and remission rates were almost 45%. But those who didn't respond were offered escalation to the 4-food elimination diet, and then eventually the 6-food elimination diet if no response was seen. In non-responders to the 2-food elimination diet, stepping up to the 4- and 6-food diets actually showed similar remission rates than we've previously seen. And compared to the 6-food elimination diet, this allowed fewer endoscopic procedures, this shortened the diagnostic time, and any risks associated with the procedures or complications from the procedures. There are also allergy-based elimination diets, and this is where skin prick tests, serum IgE tests, and ATP patch tests are used, and then foods are eliminated that caused positive results. And currently we've seen that these allergy-based elimination diets have lower remission rates than the other empiric elimination diets that I mentioned. In 12 single-arm studies, 49% of subjects failed to achieve histopathologic remission. This was compared to 86% from the placebo group. But again, this is kind of low quality evidence because it's due to non-comparative single-arm study designs. And caveats to this is that patch testing could actually be more effective. And aeroallergens as triggers for EOE have not currently been investigated thoroughly. Dilation. So dilation and EOE. There are no specific techniques that are shown to be more effective or safer in EOE. Typically, when you have a severe narrow caliber esophagus, we'll start with a wire-guided savory dilation, and for focal strictures, a through-the-scope balloon dilation. And so in this patient, a 45 French or 15 millimeter savory dilation was done that, as you can see, showed a nice long longitudinal rend there. And remember to always warn patients about post-procedural chest pain, and this patient almost certainly did. So why should we dilate an EOE? Well, we know that endoscopic improvements with topical steroids are actually limited to these endoscopic features that you see, so exudates, edema, plaques, and rings. And strictures have not been shown to improve or resolve with steroids. On the flip side of this, dilation also doesn't treat the inflammatory component of EOE. So this was a group at UNC studied by Dr. Dellen's group again, and essentially they looked at a group of patients who were treated with topical steroids for an 8-week course and followed them over a median of 19 months. And so those patients that responded to steroids had less than half the number of dilations in the group that didn't respond to steroids. So 1.6 compared to 4.6. And this was a significant finding and really reiterates that we should be using both to decrease the number of procedures, the sedation exposure, the complication risk. Risks of long-term therapy. Well, this group evaluated the budesonide oral dispersible tablets for about a year and showed that the risk of candidiasis was about 11 to 16%. But when looking at systemic absorption of the steroids, it was really minimal. And they evaluated that with mean AM cortisol levels that showed no change between the placebo or the treatment groups. Should we be using EGD to assess patients after we change therapy? Well, all these studies, even though they're not higher quality trials, show us that yes, we should, because we know that symptoms only modulate with disease activity. Patients probably over a lifetime have developed certain behaviors, drinking liquids with meals, avoiding meats or breads, that symptoms and biologic activity do not actually have a linear relationship. So who would be a candidate for maintenance therapy? We should be thinking about it in patients with a narrow caliber esophagus with severe stricturing, who've had recurrent food impactions or symptoms that return right after finishing therapy, or those that have had prior spontaneous or dilation-induced perforation, or just at baseline for their other comorbidities for having an endoscopy and dilation. Our future directions, well, we need to have uniform endpoints among clinical trials for comparisons between therapies, and we need head-to-head studies for therapies. We need to understand why symptoms continue despite histologic remission, and what the effectiveness of these combination treatments, PPI and diet, PPI and steroids, are for patients. We still are needing prospective data on the natural history of EOE to determine who actually needs and why maintenance therapy. And then we truly need measures of quality of life and nutritional status as outcomes, more than primarily the histologic outcomes that we've looked at so far. So in summary, make sure to take multiple biopsies from multiple levels and use your clinical context to diagnose EOE. Know that symptoms don't correlate well with esophageal eosinophilia, that there are no FDA-approved medications for EOE currently, and the treatment of EOE includes these 3 Ds, drugs, diet, and dilation. PPIs are now considered first-line treatment for EOE. There's no superiority of viscous steroids over inhaled. Biologic therapies are still under investigation, but have shown some promising results. Dilation combined with therapy reduces the number of future dilations and risks associated with that, and recurrence occurs rapidly after stopping therapy. Thank you so much.
Thank you, Dr. DeLay, for this excellent presentation to kick off our meeting this morning. Greatly appreciate your time. We do already have some burning questions, but we'll share those for the panel discussion.